Cool. Okay, hello everyone. My name is Christine Liu. I use she, her pronouns. I'm the director for the ASUW Student Disability Commission at the University of Washington. Just in case you're not familiar with Zoom webinars, I'm just going to give you a brief overview of what you see at the bottom of your screen right now. You should see a chat box. If you'd like to add any comments there, you're more than welcome to. If you have any questions though, please send those to the Q&A box that are right next to that. There's a raise hand option just in case you'd like to add a question or a comment instead of typing it into that Q&A box. In case like typing is just not your preferred mode of communication, that's totally fine. Just press that raise hand button and I should be able to see you, and hopefully we'll be able to unmute you. Let me see the Q&A box. Just go ahead and type in any comments or questions there. We'll be able to see them pop up on our end. For CC is closed caption. If you press that button, it'll give you an option to either have a subtitle on the bottom or the full transcript on the side, whichever you prefer. This event will be recorded. It'll be made available later on the STC website for asynchronous access. If you don't wish to be recorded, just leave your mic off. Your name doesn't show up anywhere, so it shouldn't be a problem. Attendees will be muted at all times unless asking a question. We'll only have one panelist video on at a time to ensure there's a clear visual of the ASL interpreters at all times. A question came up a little bit ago also that was asking if you'd be able to ask questions in ASL. One of the things about the Zoom webinar, I don't think it allows me to turn your video on. So you have to ask questions through the chat. I'm really sorry about that. That was an oversight on my part. Hopefully that will be all right. You are free to ask questions at any time. We'll be mainly answering questions at the end. We'll have kind of an open Q&A session. If you'd like a specific panelist to answer your question, just add their name next to your question submission. Yeah, there will be a short bathroom break in the middle. I know I'm gonna wanna go use the bathroom. This thing is 2 hours, so just so you're aware of that. And before we get started, I have a few acknowledgements I wanna give as well. For those of you who are not at the University of Washington, there's sort of a land acknowledgement that we do before the beginning of our events, so I wanna read that. The ASUW acknowledges the stewards of the Coast Salish lands, the lands on which we currently sit, and the UW occupies. We acknowledge the original and current caretakers, the Duwamish, Squamish, Tulalip, and Muckleshoot tribes, nations, and peoples. Right. I also want to acknowledge that being able to work from home takes a certain privilege, and I want to say thank you to all the people who do not currently have that privilege, whether they be restaurant workers, doctors and nurses, grocery store employees, anything. Thank you for being out there. Trigger warnings, just so everyone is aware, we will be discussing topics like fat phobia, ableism, eugenics, domestic violence, racism, and anti-Blackness. There are many other aspects of COVID-19 that we will not be discussing in depth today. There is a lot of racism and xenophobia, disproportionate access to healthcare for communities of color, many people experiencing homelessness and poverty, and many people experiencing domestic violence at this time due to the pandemic. We want to acknowledge that these things are happening and people really do need to be aware, even if these are not things that we're focusing on today. This is a safe space. We are speaking from our own identities and experiences, and that should all be valued, so please have patience and respect for each other. And now that all of that is out of the way, I'm so happy to introduce you to our wonderful panelists for today. Thank you all so much for being here. I'm gonna let them sort of briefly introduce themselves, starting with Mary. So let me go ahead and start your video if that's all right.
Well, my name is Mary Fashik. I am a writer, a disability activist, and the founder of the Upgrade Accessibility Movement.
Awesome, thank you, Mary. All right, and then next we have Clarkisha. Let me go ahead and start your video for you.
Hi, I'm Clarkisha Kent. I'm a writer for Wear Your Voice magazine. I've been writing actually for a couple of years. Yeah, just I write, but I also specifically focus on, racism, ableism, misogynoir, yeah, and fat phobia, most importantly.
All right, thank you so much. And then we've got Joe. Let me go ahead and start your video. All right, there we are.
Okay, hi everybody. My name is Joseph Stramondo. I am an assistant professor of philosophy at San Diego State University, where I also occupy the position of associate director of the Institute for Ethics and Public Affairs. My teaching and research focuses on bioethics and tries to bring that into conversation with philosophy of disability and disability studies. And so I think that pretty much covers it. Thanks. Really excited to be here.
Thank you so much, Joe. All right, and then we've got Sheila. Just give me one moment. All right.
Hold on, the interpreter's just getting her pinned. Hi, my name is Sheila. Hello, everybody. And this is my name sign on the side of my cheek with an S. And I use she, her pronouns. And today I work at the state. I'm a state writer, lecturer, and my content, I write about travel. And also I'm a researcher. After grad school, I moved to Italy to research there. And I lived in different countries and mostly in Italy. So thank you.
Great, thank you so much, Sheila. And then we've got Caroline.
Hi, I'm Caroline. I am a writer. I write regularly for Bitch Media, Teen Vogue, Washington Post, and I have a JD from Boston College Law School. My primary focus is reproductive health. I personally have endometriosis, and so that's been a big focus in my writing and how chronic illness impacts accessibility, stigma, and gender. So, and I'm excited to be here.
Awesome, thank you so much, Caroline. We're actually going to keep you here because you are our first panelist up. You wrote an article called Cover the Coronavirus Without Being an Ableist Asshole. Love the title. And you talked about some of the different shows of ableism on social media. Can you explain some of those examples of things that you've seen?
Yeah, I think it started early on when people were being quarantined and self-distancing or isolating. And, you know, a couple of friends of mine who also have endometriosis, we would send each other tweets that we saw that were like complaining about having to work from home or complaining about having to stay home, or, you know, talking about, oh, I'm losing my mind because I'm, home for a week. And we were just sort of frustrated because, it's the lived reality for so many people who live with disabilities and chronic pain. And it felt, it was incredibly triggering to just see how many people, saw the way that we had to live as being miserable or unbearable. And yeah, it was, I think it was a little bit of a reality check too, to see, because a lot of times those are the same people who, in our lives when we have asked for accommodations, like professors or other students have acted like working from home or remote classes are a luxury, or, they're asking for it easy. And then all of a sudden those same people seem to be really put off by the idea of not leaving their house. And it was just really hard to see. And I think, obviously there were other displays of ableism, but I know that particularly was one that really struck a chord with myself and a lot of other people I know who live with chronic pain and some form of chronic pain or illness or disability that keeps them housebound for periods at a time.
Yeah, absolutely. You kind of touched on this a little bit, but maybe expand on it a little bit more. What kind of messages do those posts and articles and what does that send to people who are disabled, chronically ill, and or immunocompromised?
I mean, I think it's always hard to see people complain about realities that you don't have a say in, like it's always difficult to watch people complain about, not being able to go out to bars or travel or do certain things when you know that that's how you have to live all the time and you have no choice in it. And it's just kind of saddening to know that so many people look at, you know, the way that you have to live your life with pity or resent or, you know, negative feelings, you know, rather than just being able to have some perspective in those opinions and say, you know, right now, like you said in your introduction, being able to be home right now is a privilege. You know, it means you're not an essential worker. It means you're not on the front lines. And, you know, what's more than that is being able to miss, you know, going out and having a day-to-day life that involves leaving the house whenever you want, or going to school or going to work in a way that makes you feel comfortable and safe. Those are also privileges to live in a body that that accommodates that, and to feel like this kind of situation is different. And so I think it's just yeah, I think the word I would use is saddening, and it's frustrating because, you know, you want to shake people and be like, well, how do you think I feel? You know, and yeah, it's definitely, I think, created some tension between, I know a lot of my friends and I who live with chronic pain, and other folks that we know who are able-bodied who, you know, really can't get that same perspective. And, you know, we've had to have some hard conversations. I know a lot of us in the endometriosis community have had conversations with our loved ones and friends and said, you know, look, I know you're frustrated, but, you know, you need to watch what you say, because, you know, you're talking about a lifestyle that we don't really have a say in partaking in. And, you know, you just have to have some perspective on that.
Yeah, absolutely. Completely agree. What would you say to someone who was posting this kind of stuff? What would you recommend for them to do in order to educate themselves?
I mean, I think the word I always use is perspective. And I think it's something that I, of course, try to practice myself. You know, I live with chronic pain. I have a chronic illness, and it is pretty debilitating at times, but I also live with a lot of privilege. You know, in this current situation, I'm quarantined with a very supportive family in, you know, a comfortable home environment with enough food and, you know, space, you know, outdoor space. And I think, you know, taking stock of, you know, what your situation, you know, everybody is suffering right now. Everybody is, you know, facing some sort of anxiety or fear that is new to them. But I think it's important to keep perspective on, you know, yes, it might be really tough to be home right now. But consider, you know, the people in your lives who are home, you know, and they're also chronically ill right now. Or, you know, I know in the last couple of weeks, every time I have a pain flare or, you know, I don't feel well, it's really scary, because I think, you know, if I really need to see my doctor, that could be dangerous for myself, for my family. And I think, yeah, the best advice I would give is just try to keep perspective, try to look around. And, you know, it's not a matter of like everybody has a worse problem than you, but just try to look at your situation in relation to others. And, you know, in terms of gaining that, I think, you know, attending things like this, I always say, try to read as much like first person writing from people who live with disabilities and chronic illness, because, you know, I got sick 4 years ago, and before I got sick, I had no idea what this was like. And it's really scary. And it's also really hard to conceptualize unless you know someone who's going through it, or you have, you know, read firsthand accounts of people that are going through it. And so I would say, you know, read publications like Bitch or Wear Your Voice that I know are really committed to giving a space to marginalized writers, and read about what it really feels like to exist in, you know, a disabled or sick body.
Absolutely. Thank you for those answers. Really appreciate it. Also, highly recommend reading Caroline's article. It is fantastic. It is going to be linked on the SDC website under the panelists if you're looking for it. So thank you, Caroline. I appreciate it.
Thank you.
Right. So next we've got Clarkisha. Give me 1 second to switch this up. Hello. All right. Just making sure you're unmuted.
Yes.
Perfect.
Yes.
There we go. Okay. So you also wrote an article called, a couple of different articles, but the one that I'm referencing right now is called
Yep.
The coronavirus is putting the failings of ableism and individualism on full display. And in that article, you use the term rugged individualism. So how does that connect to sort of this trend of supply hoarding that we've seen, where people are taking Lysol wipes and hand soaps and taking a bunch of them and not leaving for anybody else?
Yeah, so it even goes deeper than that, because it's one thing to like hoard for yourself, but like we're also seeing, especially early on, people buying up like everything and then trying to resell it on eBay or Amazon before they came down on it. But like it's basically the whole like me, myself, and I thing, you know, just me, everyone, every man for himself, every person for themselves. That's where it's coming from. But the rugged individualism part is a uniquely American thing. Because like in the article, I referenced Herbert Hoover, who 2 seconds before the Great Depression is talking about, oh, rugged individualism. Americans don't need, you know, a social net, you know, bootstrapping, pull yourself up by your bootstraps and, you know, do your thing. You don't need assistance from the, you know, things like that. So it's connected to the hoarding because, you know, people are going into these stores not thinking about the next person that might get sick, which is, it's ironic, right? Because people are spreading the virus to other people, right? So it's nice for you to have your 5 different smelling like hand sanitizers and like 3-ply to 6-ply tissue paper. You know, it's nice for you to have variety, right? But if, you know, the next person can't get that mask or they can't get the hand sanitizer or the wipes or whatever, they're gonna get sick and pass on to the next person, you know. I would go into the whole like herd like immunity thing, but like I'm not a medical professional, so I have to leave that up to them. But like it's that whole thing. If one person gets sick, we all get sick. But you know, people who are subscribing to that rugged individualism model aren't thinking about that. They're just like, well, if I have mine, then I'm okay. So.
Yeah, absolutely. And that kind of connects to this next question as well. This global pandemic has started to reveal a lot of faults in the capitalist system that we live in, right? But do you think that once the pandemic is over, do you think that system will actually change?
Really, that's a very interesting question. I'm glad you asked. It's very 50-50 right now, because right now we're at a very pivotal moment, like moments that people were like dreaming about that is actually happening now, right? Like we're at a moment where people can do rent strikes, people can do like worker strikes and demand unions, like there's like a lot going on socially, you know, that can move the needle towards progress. But at the same time, it's I say 50-50 because, you know, if you go on Twitter right now, especially Twitter, you'll see a lot of people like, I can't wait for this to go back to normal, or I can't wait to, you know, for things to go back to how they were. And it's funny because I'm like, I don't think there's a normal after this. I don't think we can just return to business as usual, but there are a lot of people who either A, want normal to return, or B, are seeking, you know, the normalcy that was before this thing struck. I don't think it'll be normal, but that's not stopping people from like being nostalgic for that status quo. So it's really, it's 50-50 at this point. I'm hoping things change, but you know, people have to let go of their comfort, and I don't know if they're willing to do that. So.
Yeah, that's a major point. People are going to have to let go of their comfort, and that's a
because one thing Corona is proving is that comfort is not a priority right now. Unfortunately, safety, you know, like the literal like necessities, like basic necessities. Comfort is not really at the top of the list, but you know, a lot of people like Caroline mentioned are like still trying to grapple with that aspect of this.
Yeah, absolutely. I'm gonna switch topics a little bit to another article that I saw that you wrote. I love the title to this one too. There's a global pandemic and you chuckle fucks are still being fat phobic. Never heard that word before. I adore it. What is the message that you wanted to convey through this article, through sort of this COVID-15 thing that's going around? Can you explain that?
Okay, so I knew it was coming when, you know, states started issuing the stay-at-home orders and started shutting down the gyms, and I was like, okay, it's coming. And then Like if you read my article, you saw where I put screenshots of several companies and well-known celebrities sending out like, hey, here's my new workout thing, here's my new pill, here's a new diet I'm on, you know, just kind of bombarding. It's like worse than New Year's Day, right? Like, because New Year's is very, you know, primed for like fitness messages or whatever. But yeah, the COVID-19 thing I mentioned is about, you know, people being very anxious about gaining weight while in quarantine, right? And it's one thing to be like anxious about, because I have, you know, I've struggled with disordered eating for like my entire life, and that's one thing to be worried about, where you're holed up and you can't really go anywhere, and you're anxious. You already have a weird relationship with food, and now food is basically all you have, right? But with certain people, like literally the attitude is that they would probably rather risk getting this virus than, you know, God forbid, gain 5 to 10, 15 pounds. And it's just kind of a sad reminder how fat phobic our society is, to the point of like irrationality, you know, because that's the last thing, honestly, you should be worried about. Like, as long as you have food, a roof over your head, you know, some income is coming in to pay for the necessities or whatever, you should be good. But again, people are more worried about gaining 1 or 2 pounds than that. And it's funny too, because I'm like, it's an inevitability. Your eating is going to change, your activity is going to change. Like, just let your body do what it do. But again, people are more concerned with aesthetics, you know, because there's nothing that the CDC has put out that says, you know, fat people or whatever are predisposed to this virus, but yet people are still conducting themselves in that way. So I just wanted to point that out and tell people to mind their priorities. So.
Yeah, absolutely. What would you kind of mentioned it at the end there, but what would you like to say to people who are posting and sharing those kind of fat phobic messages?
Yeah, like get your life together. Like, there's other things you could be doing now. Like, I don't know, cook some banana bread, bake some banana bread like everyone's doing. I don't know, start a new hobby. But like, worrying about gaining a couple extra pounds doesn't really make sense to me at this point, because I feel like it's inevitable for many of us. So I feel like we should just accept it, stop psyching ourselves out about it, and just, you know, try to get through what I feel like is going to be very long quarantine, especially if people don't start buckling down. So.
Definitely. Both of those articles are going to be linked as well on the SDC website. Is there anything else you want to add before we move on to the next panelist?
Nope.
Great. Thank you so much. All right, so we've got Sheila next. Go ahead and start your video here. All right, awesome. Hello, Sheila.
Hello.
So you wrote an article as well. It's called "Deaf People Need Access to Information in Emergencies Too." And it's absolutely crucial for emergency preparedness, information, and announcements to be available in different formats and languages so everyone can understand. What are the consequences if that doesn't happen?
Yeah, so first, I really just want to clarify that informational access, if that's not available to deaf people, it can show up in different ways, as far as because deaf people may have limited English, they may not have accessible to the internet or TV. I just want to clarify that as a deaf person, those are some of the issues that deaf people do experience. So if information is not relayed in sign language, many deaf individuals, use sign language as their priority and their main language, not only captioning and reading. So perhaps their English skills may not be good. They may not be able to understand in depth what the information is about. Captioning can sometimes also have errors and cause misunderstandings if the captioning is not clear. So just talking about informational access and how important that is. There can be a lot of misunderstandings and miscommunication if people are not aware of what's happening, and that could cause a real barrier to deaf people knowing about washing their hands, wearing masks, all those kinds of very important things, coughing into your elbow. People may not know that. And so as a result, deaf people can become higher risk as a result of that. And then if they're going into the hospital or the store, again, using a mask makes it even harder for a deaf person to be able to see the communication and trying to lip read, because we're very much dependent upon the face and on the mouth moving if they do lip read. So, you know, they can rely on family and friends for that information rather than getting it directly from the government. Or, but again, sometimes that's issues because family and friends could be passing on misinformation also. Or perhaps the deaf person has no friends or family that do sign and that they can rely on to get that information. So again, sometimes deaf people just miss the information because they don't have the right person to rely on.
Yeah. What kind of message, implicit message, does that send to deaf people when official announcements or warnings or things like that aren't provided in sign language?
My own experience has been in talking with different deaf people. Honestly, I feel like we are basically just swept aside, just ignored, that our health and safety is not as important as other people because we're not getting that immediate message. Or again, being in a family where everybody is hearing, they're talking and things are just going by the deaf person. Sometimes I don't find out what is going on until later, or if ever. And again, if there's an emergency, there needs to be immediate reaction, but sometimes, you know, there is no time to really figure out how to accommodate this deaf minority. The information has to be given directly. Also, the information, it's interesting, in the recent Obama administration, an interpreter would always, you know, or periodically be provided beside the president. Since Trump has been in office, there's been no interpreter that stands beside him and that is on camera. So, you know, why is that procedure not been the same as it was in the Obama administration?
All right, and then my next questions to you are kind of regarding your familiarity with Italy and the US, since you're kind of going back and forth there. How has Italy reacted to the COVID-19 pandemic in terms of information access?
So to let everyone know, I live in the US and in Italy, and I'm supposed to go back to Italy. It was supposed to be back in March, but because COVID-19 hit, I decided to stay in the US to be safe. So now I've been looking around, you know, to see what's happened. And I look at my deaf husband who lives in Italy, my friends and family there in Italy, and the newspapers. I've been looking to keep up with what's going on there. And so the AMS, the Deaf Italian Agency, this is the sign for it, they're trying to help deaf people in Italy and with equal access and meet their needs. The government has a lot of growth pain. You know, there are a lot of, they're improving, but there's been a lot of kind of learning growth pain. So they're trying to be proactive, you know, and protective, the protective services. It's similar to the idea here with FEMA, their agency there, their emergency management agency. In Italy, they have they've taken kind of over the everyday, the newspaper and in meetings, but so far there's been no interpretation accompanying those. So I look at what's going on with them and I see similar problems, you know, just the absence of interpreters. So, but now on TV, they've been having interpreters and captioning, but so that's good so far. But later in Italy, the prime minister Sende, this is their name sign, the Prime Minister, decided to take over, and you know, the meeting's been disconnected with no interpreting and no captions once again. So the Prime Minister, when the Prime Minister finishes, and the captions come back, but you know, that's a great mistake there to not have that. So you know, there's been no interpreting when you see the Prime Minister on the screen. On YouTube, if you look it up on YouTube and watch, then it doesn't have it there either. So it's really just not fair. Or they do have it on YouTube, but it's not fair that you have to do the extra work of looking it up on YouTube when not just getting it directly when the Prime Minister speaks. So it should be there directly when she's speaking. Also, it's a big screen picture when she's speaking directly to the country, but on YouTube, it's very small on your phone. So, you know, it's just not equal access. They really, really have a lot of work to do. So that's been the situation with the government there so far. But to let you know, their emergency management company has been paying interpreters, and there's a law that the government said the government is responsible to pay for interpreters and captioners, but they really haven't been taking responsibility to do that. So you know, it's a sticky situation there. So, and let's see, also in Italy, I've been communicating through email with different deaf people, but they have been communicating through email, but you know, deaf people would need to then be able to read, and many don't know how to read and write because it's not their first language. Like myself, I struggle to read and write in Italian, and so I really depend on the sign language interpretation, like LIS, which is their sign language in Italy. I depend on seeing the information put out in sign language and not in the written word. So sorry, interpreters clarifying. So I wanted to tell a story about something that happened in Italy. There was a deaf father who had a deaf daughter who didn't know that her father was in the hospital with COVID-19. She didn't know who to contact. She didn't get an email. So they used their video relay service, and then she finally found out. But I wanted to emphasize that, you know, the access needs to be both in written and in sign language. And, you know, I'm not able to understand unless it's in the sign language because I don't read written Italian. And so I depend on the sign language communication.
Absolutely. You mentioned it a little bit already, but kind of how has the US reacted to the COVID-19 pandemic in terms of information access? So you've got Italy, how has the US been comparing to that?
It's been a little bit similar, but also a little bit different than Italy. On the top level of government, like the White House and the CDC, there's been no interpretation at all. So there's been captions, but not interpreters. The CDC has already put on the internet in ASL resources, but you know, again, you have to look for it, and it's very small, so it's not really deaf friendly. State governments have been much better with providing interpreters, but the problem is that on the highest level of government, it hasn't been. So because there's no access at the highest level of the government, then deaf organizations have partnered to try and provide that access, like, you know, for the White House communications and meetings and things like that. And so they try and include that, like the videos and the transcripts, and get those out to the deaf community. But really, the White House should be responsible for providing that. It shouldn't be up to the deaf organizations. So it's still a problem. And I wanted to clarify that you know, it's also about comfort and ease and clarification of information. For an example, my experience discussing with other deaf people here in the US, you already know, exactly how to wash your hands, how to put on a face mask, what to do if you're coughing, all of that information, but it's not really clear to the deaf community. Like, what do I do if I get sick? What are the next steps? should I go get tested? Is there a phone number I call? Do I go to the emergency room? So, you know, it's not clear in the deaf community. Am I supposed to go to a hospital? Will I have an interpreter? Things are really much more murky in the deaf community about what we're supposed to do because they're not hearing it. Whereas, you know, there should be a very clear list of what steps you need to take if you get COVID. So, you know, I know deaf people that have already gone to the emergency room, and again, there's been no interpreters there, and they've had to go from hospital to hospital trying to find a place with an interpreter. So there's problems in the system at large. And lastly, NAD, which is the deaf organization, National Association of the Deaf in America, they have provided ASL resources for COVID-19. But, you know, again, it's lists of things that you have to look up. So it can be overwhelming and it can take time and energy to be constantly searching for this information, opening it, closing different links, and kind of doing a research project. And so I don't think that most people, you know, including myself, have the time or the patience to go through this. So there needs to be an idea of how to get that information out directly to the deaf community from the national levels and the city levels, from every level of government. The information needs to be sent out clearly and directly. You know, it should be coming across on our phones, on our TVs. There should be lists of things for people. So yeah, that's it. It needs to improve.
Yep, definitely agree with that. You kind of touched on this a little bit already, but what would you recommend to US officials to improve information access and consistency?
Let me think about that. So I think I have a few ideas. We really need to set up a US pandemic team. You know, in general, in the government, there should be a team that covers the pandemic. And then under that team, there would be different sub-organizations that specialize in different parts of the pandemic. You know, so there would be one team that would focus on deaf people and how to accommodate their needs. And in every single area, there would be a different team focusing and coming up with inventive ideas on how to support communication and information access. And so there really needs to be partnerships in this US pandemic team between all of the different parts of the team, so the whole team was working together. So I like in Italy, there's clearly a setup with the different levels of government. The US needs to set up something that clearly connects every level and every part of the pandemic, every area they need to approach, you know, like in this, also the areas of the country, like the South, East, the West, the North. So in different cities. And they also need to find leaders who will be responsible for all the different levels that can work together as a team. So like on the city level, there needs to be a leader whose job it is to support the deaf community and to report back to the pandemic team on the national level. So there would be varying levels of this pandemic team in each level of government. So we really need to work together and figure out how information can be more easily accessed instead of making people have to really work to find the information. You know, like I was talking about the agency in Italy that is constantly pumping out information. And so maybe, you know, that's an idea that we can do here, like a monthly newsletter from each state, you know, or different ways to keep in touch on the internet. So, so it's more passive so that the individual deaf person doesn't have to actively search out the information. There could be a building center for like resources and lists and internet links that if you wanted to find that, it would be really easy. You wouldn't have to search as hard to get the information. For us, accessibility is not a choice. It's a necessity. And it's a right as well.
It absolutely is a right. I completely agree. We also have one question that came in from one of our attendees. Should ASL be taught in K through 12 schools for everyone? I'm assuming in the US.
Yeah, honestly, I think it should be taught all over the world, but I don't know if I would expect everyone to learn ASL and be, completely skilled in it. But I think, they need to set up some kind of community ASL classes where it's, commonly and easily accessible for people to join in. So I'm not sure if it would be required, but that would be a really good start, to just start with community ASL classes that are easy for people to sign up and take.
Great, thank you so much, Sheila. Is there anything else you want to add before we move on?
Nope, that's it. Thank you.
All right, great. Thank you so much, Sheila. And her article is going to be linked also in the STC website. So for right now, I believe we have a short bathroom break. We're going to come back around 4:50. Sound good? All right, cool. We'll see you in a bit then. All right, hello everybody. Hopefully everyone is back by now. Awesome, there we are. Hello, hello. Okay, so next up we've got Mary. I'm gonna go ahead and start your video here. All right, hello Mary.
Hi.
Perfect, okay. So I'm gonna start off by actually reading a quote from one of your articles, if that's okay. The article is called "Employers, Please Accommodate Disabled Workers All the Time, Not Just for Coronavirus." I love the article, especially this one quote. "The panic over the virus may diminish, the virus itself may be contained, but the ableism that has come to light during all of this won't vanish. It will simply be swept under the rug like it has been in the past." So can you expand a bit on the ableism that you're referencing in this?
Sure. Well, ableism is not anything new. It's always existed. And all of a sudden, these conveniences are now available. Things like curbside pickup, telecommuting, completely integrated online classes. All of these things that the disabled community and chronically ill community have been asking for years and have been denied these things are now available because the mass population, the general population needs them. That highlights the fact that this ableism has been going on. Why is it okay for those things to be available now, but when they were asked for by the disabled and chronically ill community, it was not okay. They just were being denied time and time again.
Absolutely. What kind of excuses do employers typically give when refusing a remote work accommodation request, or even professors for classes, things like that?
Well, as far as employers, I have to say it's money. It always comes down to money. They feel that having to set up a way for a disabled employee to work from home would be too expensive. And so they much rather hire a person who is not disabled and maybe even less qualified than accommodate the disabled employee. As far as schooling goes, the same thing. It's not convenient. And the attendance policies that are instituted, especially in universities, are ableist, saying that you have to be physically present in a classroom when you're not able to do that because of a chronic illness or disability. It's just plain ableism, and it comes down to organizations not wanting to accommodate the disabled or chronically ill.
Yes, I completely agree. This next question is sort of coming from me as I'm a student at the University of Washington. I have been sort of advocating for remote access for quite a while now. We have a campaign called Distance Learning Now that we've been trying to do, and now that everything is moved remote, it's a huge success. Like UW purchased Zoom Pro licenses for all of the students and faculty. The one thing that I'm really concerned about, though, is that through this, we've also seen a lot of frustrations with remote access. So we've seen people experiencing Zoom bombing, which is where you have like spammers come into a Zoom meeting or something like that, or even you have older professors who are unfamiliar with technology needed, and they are sort of pushed off of remote accessibility because of that. Do you think that those experiences will discourage people from meeting remote access needs after the pandemic has passed? Or do you think that the pandemic has actually been helpful in promoting work access remote?
I think no matter what happens, there's always going to be some excuse not to provide accommodations. I think because we were kind of shoved into having to do everything remotely, there was not enough time to work out the bugs and get people familiar with the online resources. But there's always going to be some excuse not to meet or make accommodations. I am hoping that this becomes more normal, but I have my doubts. I think when we get back to some kind of normalcy, there will be many excuses made as to why this can't go on after the pandemic.
Yeah. How can we advocate for remote access all the time, not just during COVID-19? And this kind of connects to another question as well. What is the best way for an employee who has been refused that accommodation to fight back against that? Are there support networks out there? What would you recommend for allies to do?
I think just making society aware of the fact that these things are a necessity for the disabled and chronically ill community is not a luxury. Access is not a luxury. And education and being able to work from home are privileges. And it needs to be transformed from a privilege to a right. Everyone that needs it should have the right to be able to attend school online, fully online, and also work from home. I think awareness is the key in all of this. As far as an employee being refused accommodations, there aren't very many options as far as fighting back. You can go to the Justice Department of the ACLU, but the way the Americans with Disabilities Act is written, there are many loopholes, and those loopholes are making the ableism flourish. And those loopholes are what is preventing complete access that the disabled and chronically ill community needs.
Yes, completely agree. Thank you so much for that. I definitely appreciate it. The article that I quoted will be available on the SDC website under the panelists. Is there anything else you want to add before we move on?
No, thank you for having me.
Thank you so much, Mary. Appreciate it. Okay, and then next up we have Joe. I'm going to go ahead and get your video rolling here. Perfect. All right. Hello.
Hi, everybody.
Okay, so my first question for you, you've written quite a few articles about COVID-19 triage protocols and sort of bioethics in conversation with disability ethics. What are some of the worst COVID-19 triage protocols that you've seen, and what makes them particularly?
Sure. I think that there are sort of a number of ways that triage protocols can go very, very wrong. There's been a lot of talk about quality of life judgments being part of triage protocols. In other words, deciding who gets the ventilator or the ICU bed based on judgments about whose life is going to be best for them, right? That they are going to have enough well-being to justify the use of that scarce resource. And so that's of course a really big problem, but there aren't a lot of protocols that actually explicitly use that kind of criterion. And so what's interesting to me is the ways in which quality of life judgments sort of sneak their way into some of the triage protocols. Like, for instance, there was a protocol or a set of guidelines developed by the state of Alabama that used what are called exclusion criteria.
All right, it looks like you're frozen here. We'll give you 1 minute.
Can you hear me?
Yes, we can hear you now.
Okay, where did I leave off?
I believe University of Alabama.
Okay, yeah, so the state of Alabama, actually, I don't think it was the University of Alabama. So the state of Alabama had a set of triage protocols that relied on what are called exclusion criteria, which means that it's a set of diagnoses that would just exclude a patient from even being considered for treatment that used a particular kind of scarce resource like a ventilator. And so that was sort of a way of smuggling in quality of life judgments, because a lot of the diagnoses they were sort of referring to with their exclusion criterion had nothing to do with whether or not the effective for the person respiratory illness, so things like intellectual disability or Alzheimer's. And so that seems like, because there's this disconnect between the effectiveness of the treatment and the kind of disease or disability that they were using as a justification for withholding treatment, that seemed like it was just clearly about quality of life and really, really ableist. Another way that quality of life judgments can sort of sneak their way into triage protocol is when you see triage protocols that use health criteria. Now, this one gets a little bit tricky because sometimes health criteria can matter to whether or not a treatment can be effective. And so when you're trying to use your resources to save people's lives, you certainly don't want to use, I don't think, resources on someone who will die with or without treatment. And so if it's sort of like a futility kind of situation, then you want to be really prudent with how you use a scarce resource. So, if someone is clearly dying and a ventilator just sort of won't help them, then there might be justification for using that ventilator on someone else who you could save, who the treatment wouldn't be futile for. But the problem is that health criteria can be misused in ways that don't track medical futility. For instance, the University of Washington had a controversial triage protocol that they came out with, and that sort of triggered a formal complaint from some disability rights groups. And I'm just going to quote from it really quickly, because I think one of the biggest problems with the protocol from the University of Washington is because it used language around health. And so it says that, the philosophical foundation of their triage protocol is to try to save as many lives as possible, or sort of produce the greatest good for the greatest number. And then it says specifically, quote, greatest good in a protracted clinical situation such as the COVID-19 outbreak is generally considered maximizing survival of patients with COVID-19. Okay, there's still some problems with that, but that's not too bad. Here's where it gets a little murky. Overall survival may be further qualified as healthy long-term survival, recognizing that this represents weighting the survival of young, otherwise healthy patients more heavily than that of older, chronically debilitated patients. Now, that's a problem for at least two reasons, right? One reason why that's a serious problem, I think, is that it's very easy, because disability is so often medicalized, it's very easy to sort of confuse or conflate any disability with being unhealthy, right? And so somebody who's trying to apply this protocol might read that and say, oh, well, we're trying to maximize the long-term survival of someone who's healthy. And, Joe, has dwarfism. And so that means that he's not healthy. And so we're going to deprioritize him with this protocol, right? And so disabilities that don't necessarily have anything to do with health, or at least not in the way that would be significant to something like the COVID-19 pandemic, could still be used as justification for withholding treatment with this kind of language. And then the other problem is that it considers long-term survival as a triage criterion. And that's an issue because medicine is so bad at predicting long-term survival. When you are faced with a clinical situation where someone's going to die very, very soon, you usually can be pretty accurate with those kinds of predictions. But the issue is that the farther out you make a prediction about somebody's survival, the less accurate it's going to be. And therefore, the more likely it is that you're not actually making a judgment about withholding care because of survival, but rather you're making it based on some kind of ableist stereotype about someone with that kind of disability. So I think that summarizes some of the main problems with some of the triage protocols that I've seen, and there's some others, but hopefully we'll have a chance to get into it with some of the other questions.
Absolutely. Thank you so much for that. Really interesting, especially the University of Washington one. I didn't know about that until I had seen you written something about it. Interesting, because I go to the University of Washington.
Sure.
Yeah. How are ableist protocols like this developed, and how can we fight against them?
Sure. So I'm going to sort of take these two questions in reverse. I think that the question of fighting against ableist triage protocols might be sort of the wrong kind of tactic. And what I mean by that is specifically the term fight. Now, I'm as much of an activist as I am an academic, I'd like to think anyway, and so I'm not afraid of a good fight. But I think when we're talking about triage protocols, it's not necessarily the case that we want to fight against triage protocols, but rather that we want to try to influence them to be better than they otherwise would be. And so I'll just sort of start off by saying I think what the disability community needs to do is use their voice to raise some of these issues about how the protocols are ableist, and things that I might not even be seeing because of my limited experience. I only have a couple of disabilities. I don't have everyone's experience, and so it's important that we raise these issues, try to get the triage protocols changed, rather than thinking about them as something that we need to fight against. And the reason is because when you talk about triage, there really is no good way to triage, right? In some situations, you can work to try to expand the capacity of the healthcare system to treat as many people as it can, to find innovative ways of creating personal protective equipment, or use things like the Defense Production Act to produce more ventilators, or make sure that you use a coordinated system to get the ventilators to where they need to be. So hopefully you don't need to triage. That's the kind of thing we need to sort of fight for. But when it comes to triage itself, there's no good way to do it. Even sort of some of the better ways of triaging are really bad. For instance, in thinking of some of the ways that are used, for instance, with the PIT protocol, that sort of explicitly bans using sort of quality of life judgments and this sort of thing. It makes its judgments based on survivability or the likelihood that a patient will survive if they are given some kind of scarce resource as a treatment. And that seems like it is, not as ableist as it could be, but it's still a problem because a lot of times the comorbidities that make you less likely to be responsive to treatment with something like a ventilator are produced by oppression, for lack of a better word. A lot of times we talk about the social determinants of health, right? But things like racism, ableism, sexism, and so on produce health problems for people, right? And so if you say, oh, well, diabetes is a comorbidity, and if your diabetes is significant enough, then we're going to use that to say that you are unlikely to respond to ventilator treatment, and so we're going to withhold this ventilator from you. Well, okay, but there's lots of evidence out there that something like diabetes is much more likely within communities of color, poor communities, and so on and so forth, because of access to healthy food and working conditions and so on and so forth. And so, it's not the kind of situation where we want to pile oppressions on top of each other and say, okay, well, we're going to live in a white supremacist society that creates these comorbidities for this group of people, and then use those comorbidities as a excuse to try to withhold treatment from them. That's to use one of my colleagues' terms, that's the thinking of a bunch of chuckle fucks, if you ask me. And so, there is no good way of doing this kind of triage. The best we can hope for is to sort of mitigate some of the worst ways of doing it. And so try to gain influence, try to speak out, go on social media talking about the ways in which triage, isn't helpful, and the ways that it's sort of most ableist. Right, as you see, a lot of the panelists on here are writing about ableism, right stuff. Try to encourage policymakers that are creating these policies to create dialogue with the disability community so that we can exert our power and our influence over what kinds of criteria are used. But when it comes to actually fighting, I think we need to direct those efforts toward expanding the capacity of the healthcare system, so we don't need triage in the first place.
Thank you so much for that. Perfect. Kind of moving on to this next question. You did mention this a little bit, but can you explain the disability paradox and how quality of life measurements differ depending on whose voice is being heard?
Yeah, so the disability paradox is a term that's sometimes used in health economics or in bioethics to talk about how when you do sort of survey research where you try to measure people's beliefs about how different disabilities impact someone's quality of life, there's a big gap between the quality of life judgments that a disabled person sort of makes about themselves and the quality of life judgments that people that haven't experienced that disability would sort of make as somebody from the outside looking in and sort of say, well, I predict that someone with a spinal cord injury is going to have a very dismal life, where you have the actual person with the spinal cord injury saying, well, actually, I have a pretty, decent life. It's not any worse than anyone else's, right? And so this empirical evidence with these survey studies are usually, or sometimes anyway, called paradoxical, because there's this question of, well, why? Why do people that experience the disability not regard their life with the same kind of grim outlook as someone who's sort of on the outside looking in? And I think this speaks to one of the other panelists, I think it was Caroline, who was talking about some of the ableism that was expressed around how horrible it is to stay at home, right? And how, well, this is, you know, the lived reality for a lot of disabled people. And it really isn't that horrible. It's just sort of one way of being, right? And so there's this sort of paradox that's created between, you know, one group of people that's making a judgment about, you know, what it must be like, how horrible it must be like for someone else who has a different experience. And I think that disconnect is really just really easy to explain. It's not really that paradoxical in my view. I think it's just stigma, right? It's just stereotype and stigma. It's you know, as a culture, we are taught to respond to disability with pity, and to regard disability as tragedy. And so it's not surprising that someone who is on the outside looking in is going to see, you know, someone's life that has a disability that, you know, might experience the world in ways that are different from them and see sort of a pity case. That's just sort of, you know, there's literally hundreds, maybe even thousands of years of cultural norms that sort of tell us that that's the case.
Definitely. And kind of going back to a bit of the conversation that I think I had with Clarkisha about sort of capitalism and this rugged individualism, how are the quality of life measurements connected to capitalists and the society that we live in and whose lives are inherently valuable?
Yeah, no, this is great. So when I think about intersectionality, I think, to me anyway, and maybe this is just sort of because of my own experience as someone with a disability that's genetic, when I think about intersectionality, I think that one of the best examples of intersecting or overlapping oppression or interlocking oppression has to do with the idea of eugenics. And so the basic idea that I'm trying to get at here is when you are dealing with eugenic ideology, you have ableism, sexism, racism, most, if not all, of the isms wrapped up into one tidy little uh, package of nastiness. And so it's interesting how intersectionality is sort of expressed by eugenic ideologies, and how these oppressions sort of are co-constructed, if you will, and how they sort of rely on each other in some really troubling ways. And so you have an ideology that says, well, you know, people of color are of less value to our society because of XYZ horrific stereotype that is usually put in very starkly ableist terms, right? About, you know, terrible beliefs about, you know, racist beliefs about how people of color are less than white folks, and the less than is almost always described as somehow disabled, right? And so when you talk about the ways in which capitalism has influence over quality of life judgments, I think that you can look directly at eugenic ideologies and how they are sort of co-constructing different oppressions to describe people's value or lack of value or supposed lack of value to society as not being productive enough, as not being good citizens in some way or another. And then, you know, because, you know, that's sort of out of fashion now, we can't sort of say, well, we need to avoid creating these kinds of people because they're not productive enough. Instead, we have to dress it up and talk about how, you know, it's for their own good that they aren't brought into the world, or that they must be somehow normalized, right? And so we dress it up by talking about quality of life standards. and we say, we need to withhold the ventilator because we need to create healthy people, because we want healthy people to exist for their own good, because everyone's happier if they're healthy. When in reality, it's not that everyone's happy if they're healthy, but rather it's that people that are supposedly unhealthy cost more and aren't productive enough, and so on.
Yep, completely agree. Thank you for that. That was a wonderful description.
Thanks.
Yeah, is there anything else you want to add?
Yeah, I think the only other thing that I'll say is that I invited my students to join us today and told them that they could get extra credit for describing something that they learned with a short writing assignment, and everything is on the table. I've learned a ton during this webinar, and so I'm really grateful for the other panelists and what I learned. But the one thing that y'all can't use as what you learned is you can't talk about how you learned the term chuckle fuck. Everything else is fair game.
That's perfect. Thank you so much for inviting your students. I saw that in a couple of their registration forms. That was awesome.
Cool.
All right, great. So I think this next question, I first want to go over some of the questions that have been posed in our question and answer chat. The first one here, let me see. I'm going to go ahead and turn your video off if that's all right, Joe. Perfect. Oh, you got it. Okay. This first one I think is aimed at Clarkisha, so I'm just going to turn your video on here. It says, I feel like a lot of the self-care messages I see are surrounding fitness. Although it is important for us to maintain health, it's starting to really feel frustrating being bombarded with messaging that if I don't make time to work out, somehow I'm neglecting my self-care. How do you think we can battle this messaging with each other?
All right, and that was Angela. Thank you, Angela, for asking that. So first of all, I'm very glad that I get to clarify this. So something that we all need to know about the terminology self-care is that it was actually, the definition that we derived from it actually came from Audre Lorde, Black lesbian feminist, right? She brought it up in her text when she was going through cancer a second time. So for her, it was an act of like radical existence. I'm literally prioritizing myself for my literal survival, right? And that looks different to Black women. But the point was to literally, take care of your basic necessities, focus on yourself, especially, basically give yourself pause in a very capitalistic driven society, right? So if we're taking that framework, as Angela mentioned, a lot of self-care is attributed to exercising or, eating healthily or whatever. So we really just have to start there and kind of question like, okay, why does self-care involve me subscribing to this weird mode of basically something else that's been appropriated by, the fitness industry, weight loss industry, yada, 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 yada. So I guess the best way to kind of counter that messaging is to determine what self-care means for you, for Angela or for Clarkisha or whoever, like what does that mean for you, right? For me, I like to nap. I just turn my brain off and I go to sleep. It doesn't matter how long I'm asleep, I just disconnect, right? But that, that looks different for everyone. So you first have to, again, start with yourself and figure out what that means to you. And hopefully once you figure out what that term means to you, you can kind of block out that messaging. But yes, I feel you. They are really laying it thick right now with the fitness thing and the weight loss thing. And I feel for anyone who's struggled with that period because the messaging is very intense right now. I had to mute several terms on Twitter for that reason because I didn't want to see it. I didn't want to see it. So
thank you so much for answering that. I actually have another question that just came up that might be good for you to answer as well, since you're already here, if that's okay.
Yes.
It's from an anonymous attendee. For any panelist, so many of you seem to be using writing as an outlet to point out ableist, fatphobic, bigoted social structures, societal structures, my bad. And I'm curious why you chose writing as your tactic to do this. Is there something about writing that makes it a good conduit for this type of information? Personal preference? Are there any other artistic outlets you use for a similar purpose?
That's a great question. I used to debate in college and also in high school. So words in particular have always been just kind of the easiest way I can use to get, messaging across. And I treat writing like, having a conversation. I'm taking the conversation I'm having with myself, and I'm pushing that conversation to the world to see if other people want to engage. So for me personally, it's kind of the most basic way that I can literally express myself, but also express the points I want to get across to the world.
Thank you for that. Are there any other panelists that also want to answer that question, since a lot of you are writers?
I can weigh in there.
Cool. All right. Gonna turn off your video here and then turn on yours. All right, great. Go for it.
So I'll just say for me, so my undergraduate degree is in journalism, and I went straight from undergraduate to law school, and I got sick in my first year of law school about halfway through, and started writing. I had done like some very like minor freelancing prior to that, but got my first piece that got a lot of attention writing about my experience getting an endometriosis diagnosis and being disbelieved by doctors for so many years, and really struggling with that. And I always say I feel bad about it, because I know that when you write about these things, and I'm sure Clarkisha experiences this, like people are really helped by it, but it is always first and foremost a form of catharsis for me. And I like writing because it lets me process what I'm dealing with in a very organized, clear way. And I can sort of take the chaos of living with a chronic illness and funnel it into something that I can feel really proud of, and that I can sort of look at on paper as like a concrete reflection of my own experiences. Because I think when you do live in a chronically ill body for so long, your sense of reality morphs a little bit. And, sometimes when you actually see your own experiences written down, you realize like, oh, like, wow, that really was scary, or that really was traumatic. And I do understand why I have these feelings about it now. So that I think has been huge for me in terms of writing. I am not creative in other ways. I don't have any sort of artistic talents, but I think that, I have a lot of friends who are not freelance writers, but who also live with chronic illness. And I know that they find a lot of comfort in activities like journaling. And so I do think that there's a catharsis in sort of like purging your experiences and getting them onto paper. And I think for me, at least, that's why writing has been such a productive catharsis in the process of getting sick and getting used to being sick, and, going through recovery phases and, recurrences. And I think that, for anyone who's sort of looking for a creative outlet to process, it's really rewarding. And it does also connect you with the community. Like a lot of my closest friends I've met because we've read each other's articles about endometriosis. And, we've said, I recognize that person. Like I recognize those feelings and those experiences. And so I think, it's also a really great way to connect with others.
Great, thank you so much. Is there anyone else who also wants to speak on that topic before we move on? Okay, cool. So before we go into a couple different questions that were also written before this, Mary, I've got a few questions for you that were put in the Q&A that I want to go through, if that's okay. All right, awesome. Okay, so the first one that came up here is from Lauren, and it says, for Mary, how do you recommend university students take this time to advocate for our accommodations and fight ableism in the classroom?
I'm assuming they mean non-disabled students or disabled students?
I'm not sure. All I see is fight for our accommodations and fighting.
Okay.
Yeah.
Well, I think that has to start with the um, Disability Services Office. From my personal experience dealing with them as a student and now as an activist trying to advocate for others, I think we need to break down the wall of ableism. I think a lot of people who work in these offices are not disabled and do not understand disability. And I think until we get administration and we get officers of disability students that understand disability and what the disabled students need, there won't be any changes made. So I think that, starting with suggesting that a disabled intern work in disabled students services, that might be a good step and a good start to kind of breaking down those misconceptions and those prejudices and the ableism that we see.
So much for that. Okay, so another question that we also have for you is from Katie, and it says, for Mary, post-pandemic, do you feel like the special time set aside for elderly, disabled, immunocompromised people to shop at stores should be something that remains? Do you feel like that would be safer to continue this practice even when we are, quote, okay?
Well, I think as someone who is disabled and chronically ill, I would definitely benefit from having a special time set aside. And I know other people in the disabled and chronically ill community will benefit from that. But again, we're talking about money. Businesses will not necessarily see any profit from doing that. They do not see the disabled dollar as having the same value as someone who's not disabled. So while I think that would be a great thing to continue, I don't see it happening.
Thank you for answering that. And then we've got one more for you. This is from Rachel. One of the themes of your articles is that society centers on and prioritizes the needs of able-bodied, healthy, privileged people. Another theme is that society demands gratitude for minimal accessibility. Yesterday, I saw an article in the Harvard Business Review titled, "That Discomfort That You're Feeling is Grief." It was talking about coronavirus disrupting normal access to society and the grief that it brings. And all I could think about was the long-term discomfort or grief that many marginalized people experience due to inaccessibility and exclusion. My question for you is, what are your thoughts on the discomfort and grief that many disabled people experience from inaccessibility and ableism?
Well, I think it's not so much grief as maybe anger, and definitely discomfort. I think it comes from the fact that many people who are not disabled and are healthy do not know how to interact with someone who is disabled or chronically ill. So because they're uncomfortable, they make the disabled or chronically ill person feel uncomfortable as well, and also feel as though asking for something like a ramp or automatic door would make the business owner uncomfortable. I shouldn't ask for my right because I don't want to make anyone else feel uncomfortable. So I think that's, I think by being conditioned by society that we do not have the right to ask for accessibility, that's what our our feeling of being uncomfortable come. And I don't, like I said, I don't see so much grief, maybe grief on the part of the non-disabled people. But for us, I believe it's mostly anger.
Thank you so much for answering that.
Thank you.
So we do have a couple more questions in this chat, but I first want to bring up some topics that I feel are really important before we get to those. So this is open to any of the panelists, whoever would like to answer. How do we feel about the initial rhetoric behind, quote, underlying conditions and the related terminology, along with, quote, the elderly and, quote, immunocompromised, et cetera, to downplay the spread and seriousness of COVID-19? How did ableism play into this? Does anyone want to answer that?
I can weigh in on that.
Yeah.
I think, you know, obviously there's an inherent ableism and very eugenicsy flavor to being like, you know, only certain kinds of people are going to get sick from this. And, you know, that should be a comfort, you know. And at first, you know, I think when the discourse really first started around COVID, it was horrifying to turn on the news and everybody, you know, anchors and, you know, people on social media, friends, professors, you know, people that you really wanted to trust and count as allies or respected sources were using that language that, you know, the good news is that, you know, it's only older people and immunocompromised people who are at risk. And you have to kind of look at that and be like, well, who is that good news for? And, you know, the answer is, of course, able-bodied, healthy, young people. And, you know, what we know now is that, you know, this is not a disease that, you know, you know, that people are immune to just because they're young or healthy. And I think, you know, what we're seeing now with young and healthy people or people without chronic illnesses or without, you know, immuno conditions is, you know, we're seeing those people dying or being made gravely ill from this. And it's a real wake-up call that maybe if from the start we didn't have this, you know, fucked up idea that some lives are more valuable than others, or it's more of a tragedy for some people to get sick than others, you know, we wouldn't be in this position where we've completely misjudged the potency of this virus, which is that, you know, it certainly can affect certain people differently and more severely, but that really no one is immune from having, you know, the worst or a fatal case of it. And I think even more than that, you know, one thing that I always say when I talk to people about chronic illness is, you know, life comes for everybody. And I think, you know, people like to think that the decisions that they make and the lifestyles that they lead insulate them from illness. And I think that, you know, that goes back to this idea that if you're sick, there's something you did wrong, or there it was, you know, it was your fault. And we see that in all aspects of medical misogyny, fat phobia, all elements of health discrimination, right? Is this idea that if you take your vitamins and you go for a morning run and you're up at 6 a.m. and you drink 8 glasses of water, that you're going to be healthy. And if you don't do those things and you do get sick, or if you do those things and you are sick, then it must be something on you and it must be something you're doing. And I think when we see this rhetoric of, well, it only affects certain people, there's almost an element of blame there. Like, well, it only affects people who are sick. And, you know, if you're not sick, then you're doing something right. And you're being good and you're lucky and, you know, you've earned that. It's something very weird. And I've always read that into the subtext of, you know, comments about health and taking care of yourself, you know, as if it's something that you can control. But I think as a lot of people, and I'm sure people on this panel can attest to, people watching can attest to, is, you know, when you do become chronically ill, when you do, you know, become disabled, if it's something that happens over the course of your life, you realize how little control you have over those things. And I think that able-bodied people have a real difficulty grasping how little control they have over their health. And so when I hear people say things like, well, it only affects the old people or the immunocompromised people, what I hear is, you know, a sense of denial that they're not safe from it. And obviously there's ableism in that too. So, you know, there's the obvious element of this is just like straight up eugenics to say that some people are going to die from it, but it's okay, or it's not as big of a worry because those people are worth less. But then there's the element that I think a lot of people who have not faced chronic illness or disability in their life have a really hard time grappling with the fact that these, experiences are out of their control, and, it has nothing, and there's nothing inherently blameworthy when it comes to being ill. And so I think that's the other thing that people have a really hard time wrapping their head around. And, sometimes it's not until they realize how susceptible they are, or, when you see people and they're shocked that, somebody's 37 or 25 and they've died from COVID. And it's like, right, because people of all ages can get sick. People of all ages can be disabled. And, if we had realized that a couple of months back, we might be in a different position. It's the same thing you see, like when people say like, oh, well, you look great. You get that a lot, I think, with people who have invisible illnesses like endometriosis. People will say, oh, well, you look fine. And, that's gaslighting, but it's also this assumption that wellness can be determined by how you look. And so we see the same thing with young people. Like, I can't believe somebody who is this age has COVID and died from it. It's just, people need to realize that, the sooner people realize that having an illness isn't something that you can blame somebody for, or something that, you can wellness your way out of, I think the sooner they'll realize, that some of that rhetoric, led to the mishandling of this disease, led to the idea that young people could still be out and going to school and going to work, or people who weren't immunocompromised could still be going shopping or partying. And if we had a better sense of how susceptible and vulnerable everybody is, then, I think we would be in a different place right now.
Thank you so much for your comments on that. Is there any other panelists who also wanted to comment on that question?
I'd like to.
Absolutely.
Just one other thing I wanted to mention is the one of the problems with talking about certain people being vulnerable is that a lot of times that rhetoric naturalizes the vulnerability. In other words, it sort of talks about how, well, it's something to do with their biology that makes them vulnerable. And I think that the picture is a lot more complicated than that. And I think that we need to recognize how some folks that are vulnerable to this disease are vulnerable because of certain social arrangements that put them into vulnerable places. This is an idea actually that I'm getting from a blog that I read regularly called Biopolitical Philosophy that has been really influential in my thinking on COVID-19 and a lot of other things. But the basic idea is it's not necessarily that the elderly are dying in huge proportions because they're old, so much as it is that they're dying in huge proportions because they're in congregate care settings a lot of times. And so if you take a bunch of people and you put them in a nursing home, it's, the virus is going to spread through that nursing home and kill a lot of folk. And so, we need to think about how we frame the issue of fragility or vulnerability and these kinds of things, because a lot of times it can fail to recognize the ways in which we as a society are making people vulnerable by the way we ignore them or throw them away, for lack of a better term.
Absolutely. That's actually kind of a perfect segue into the next question / topic that I have here. And that's talking about the really, really close relationship between ableism, poverty, and racism, right? So talking about these social situations that people are in that make them more susceptible. Is there anyone that wants to comment on that? I've got here, I'll read a little bit more about it. For example, it would be wise to acknowledge that many Americans in general have more, quote, underlying conditions, so chronic illnesses, disabilities, et cetera, that make a majority of us more susceptible to COVID-19 than we realize. But we wouldn't know this because of an inadequate healthcare infrastructure. In addition to this, COVID-19 is especially ravaging disenfranchised communities of color, so Black, Brown, Native people, et cetera. So think diabetes, high blood pressure, but also lead paint and asbestos in schools, all of that, due to the fact that communities of color are way more likely to live in polluted areas that would make them more vulnerable to COVID-19. Is there anyone of the panelists that would like to comment more on this? All right, well, either way, I'm glad that we're bringing it up because it's definitely an important topic. I've got another question here. We'll go back to our attendees' questions. How about that? Okay, so we have a question from Teresa. One of the effects of COVID-19 pandemic has been a move to telemedicine more generally. Since disability is so variable across individuals, I wonder if any of the panelists would be able to comment from their knowledge base on the effects of this move to telemedicine. Are there ableist practices embedded in telemedicine structures that you have experienced that are distinct from those in face-to-face settings?
I can jump in on this quick as well.
Yeah, absolutely.
So I, as part of my pain management for endometriosis, have a narcotics prescription. And already, as I'm sure other people have experienced, getting a narcotics prescription is incredibly difficult right now. I take a medication called Tramadol, which is, it's a pretty low level painkiller. It's not quite as strong as an oxycodone, though I have been on oxycodone as well for pain. And in order to get Tramadol in a normal situation, so not in the current pandemic, I have to go into my doctor and get a paper prescription. I have to go in for a checkup. I only get 30 pills for 6 months. I have to answer a lot of questions about how often I'm taking them. And if I want a refill, I have to, again, go into the office. I never can get a refill ordered straight to my pharmacy, because pharmacies need a paper prescription for use a paper prescription for to fill that kind of prescription. They can't take it digitally like they would like a birth control prescription. So with the pandemic, initially places like CVS, we in my family had started doing telemedicine for other drugs, including things like Ativan, heart pressure, blood pressure medications. And we were initially told that both the Ativan and the Tramadol were not able to be delivered. We would have to go into the pharmacy to get those. So you can imagine the frustration of being a pain patient, first of all, and having to go into the office for these prescriptions, on a normal day in normal circumstances. It doesn't really make sense to make a prescription, that is for something as critical as pain management harder to get, right? And so my doctor who prescribes them, my gynecologist, was kind enough when this all started to allow me to put in that order through the phone, and for her to have a hard copy faxed to my pharmacy, which was kind of interesting because I remember thinking to myself, well, if this was an option all along, if this was possible, why haven't we been doing this? Why have I, had to make a special trip into the doctor to get this prescription? Sometimes I would have needed a ride. Sometimes, I needed help getting to the doctor. And it was really frustrating. And so now, this is something that we've all been talking about, is all of a sudden these, situations that would have been helpful for us before are now available. And it's sort of like, well, where was this the whole time? So after I was able to not go to the doctor, CVS, our pharmacy, said, well, that's fine, but we can't deliver Tramadol. You have to come and pick it up because it's a controlled substance. And again, that was really frustrating to have to go through that and say, well, wait a minute. No, like I need this to go about my day. I can't drive on it. And eventually went through my insurance company, called the pharmacy 10 times. And they finally said, because of COVID, they were starting to ship drugs like Tramadol and narcotics through the mail. But it took a while. And it was a week of phone calls and back and forth with my doctor and the pharmacy. And it was really, really, really stressful, thinking about, you know, the fact that my parents who, you know, are in a higher risk age group might have to go to the pharmacy to pick up a prescription for me, you know, because of these draconian laws or policies that we have around pain management medication. So I think that was something that I ran into personally with telemedicine. And I'm sure that there are so many other stories with drugs and rules about what can and can't be sent through the mail. You know, I know that a lot of my friends, myself included, who rely on medical marijuana too, are having a really hard time accessing medicine right now, which isn't technically a specifically telemedicine based issue, but it is an access issue. You know, when dispensaries are closed, or, you know, regular routes of access are shut off because it's considered recreational as opposed to essential medicine. So that was just my experience with telemedicine. It was something I've never come across before, was that, you know, there were certain drugs they couldn't just put through the mail. And I was very grateful that eventually they did remedy the situation. But there was no need, especially since apparently it was possible to remedy it, there was no need for us to go through all of that stress, you know, to have a medicine that's necessary and safe and, you know, regulated by a physician. So that was just my experience with telemedicine and some ableism that I think, you know, obviously wasn't considered in the procedure.
Absolutely. Thank you for that. I believe Sheila also is jumping in on this question. And just a heads up, we've got about 10 minutes left, so we're going to try to keep answers short if that's possible. I do want to get through the rest of the questions that have been submitted if we can.
Hi, can you see me all right? My own personal experience was when I was in Italy last month. I had an eye infection, and my family doctor refused to see me because he didn't want to see me in person. So there was no video relay that I could see, so I had to email the doctor, and the doctor would call on the phone, but they had already set up a previous system with email. And so again, whenever I have a new doctor, that was a problem. So trying to set that up just in the system to be able to email different doctors was more of an issue. So I could not go in person. So we had to figure out some way. I kind of had to do a self-diagnosis, you know, and I had to go online and figure out, you know, that this was probably an eye infection. And I emailed the doctor and told them that maybe this is what I had. And then they wrote the prescription and they scanned it, and then that was emailed, and then they printed it, and I was able to take it to the pharmacy. But, you know, it wasn't really successful. It wasn't any kind of improvement. So, you know, again, this idea that I'm not getting direct information from the doctor, you know, I don't know, again, if there's more than one type of infection, or whether they would have had a need to write a new prescription, you know, and scan it again and send it out. And then my husband printed it out. So anyway, I felt like telemedicine was perhaps a higher risk, since I had to basically do my own diagnosis. That's all.
Excellent. Thank you so much, Sheila. Okay, so I'm going to quickly move on to another question that was in the chat. Would anyone be willing to speak on the intersections of ageism against older people and ableism during the pandemic? Perhaps Professor Stramondo. Joe, are you down for that?
Yes, I am, if I can figure out how to use my computer. Hold on one second.
All right, perfect.
Okay. Yeah, I mean, I think a lot of, not all, but a lot of ageism is almost a form of ableism, in that a lot of the fears that folks have about getting old have to do with losing abilities. And I guess one thing that I would mention is that we all have this sort of fear of losing abilities, and that there is, you know, always a transition cost. I mean, some of my disabilities are acquired, and some of them I was born with. And for the ones that were acquired, I had to get used to it, right? I had to sort of learn how to be disabled in some way. And that was, you know, a process, a difficulty. But that doesn't justify sort of the level of uh, sheer terror that a lot of people have when thinking about getting older and becoming disabled. And so I do think that this is another example of sort of an interlocking kind of oppression. In practice, we see that, you know, it's, you know, our elders as well as our disabled people that are, you know, warehoused in nursing homes and other sorts of institutions. Um, and in, you know, in more theoretical terms, I think that you know, a lot of times this kind of thing happens because of beliefs about people not being productive enough within a capitalistic society, and how again we see sort of ideas about productivity come into play when thinking about ageism and ableism. I hope that answers your question.
Awesome. Thank you so much, Joe. And I believe Clarkisha is also going to say something on that.
Well, can you hear me?
Yes. Give me one second.
Okay.
Your video
Yes,
here.
thank you.
All right. There
Okay,
you go.
well, Professor Stramondo really touched on most of it. But yeah, you know, there's the fear of aging, and definitely the loss of abilities. But another element I would take it back to is the whole like individualistic thing. You know, America's not a communal society. You know, it's very individualistic society. My parents are Nigerian, and Nigeria is a more communal thing. And so when it comes to elders too, like the whole family, you know, chips in to make sure, you know, elder mom is taken care of as she ages, dad is taken care of, your grandparents, your great aunt, your great uncle. Like there's no lack of community for elder people in certain places. But in America, that's not the case. A lot of us know people who just kind of toss their elderly aunt into the home, or maybe their mom or dad or whatever. Like we've specifically crafted this society where after a certain age, you just kind of get tossed away. And I do think it is connected to ableism ultimately, but I think we always have to keep in mind what kind of society we live in and how like me centered it is. So, and that me thinking does not leave any, you know, empathy over for old people.
Absolutely. I actually have a question that was for you, Clarkisha, as well.
Yes.
This is probably going to be our last question. I think what I'm going to end up doing, since there are a couple questions that we didn't get to, I think I'm going to post those questions on the SDC website and invite the panelists to answer those there, if that's okay. I want to make sure that everything gets answered, but I do want to respect the time of our interpreters, our panelists, and our captioner as well. So last question here. From Anonymous, many teenagers these days have to deal with fat-phobic parents on a daily basis. Some telling their children that they look fat, that they need to lose a couple pounds, they should stop eating so much. What is your advice to these teenagers who are experiencing fat phobia from their own parents?
So there's a lot of layers to this, right? Because on one hand, if you do have parents who are like open-minded, but just obviously have succumbed to societal messaging about fatness and fat phobia, then you stand a better chance of like literally pulling your parents to the side and being like, hey, mom and dad, or whatever like parental configuration you have. I'm just using an example. But hey, I didn't appreciate that comment you made about me wearing that shirt or like eating this thing. Like, and you can kind of start that conversation with your parents early and being like, hey, this is not okay. And when you say that, when you, my family member, my loved ones say that fat phobic thing to me, this is how it makes me feel, right? Now, when you're in a situation like I was, where like my parents were very abusive, very narcissistic, actually, you know, not at all open to any type of individuality that a child is displaying, you kind of have to take that to the chin from them initially, just for your own safety, but definitely kind of yourself look into other outlets or other, especially online communities, if you have access to that, that can kind of help you mitigate that, or deal with that in a very constructive way, away from that hostile, abusive, environment. And I think this is very important, considering now that, you know, a lot of those same kids are stuck in quarantine with those same parents. So that's what I would advise. Like, it's going to be really important right now in this moment to kind of reach out to those online communities who know what you're going through.
So much for that. Since it is time to end, I'm just going to, hello, I'm back. Thank you so much for attending. I really, really appreciate it. I learned a lot. I really hope that you all did too. Thank you so much to our panelists, to our interpreters, to the captioner as well. Thank you. If you would like to learn more about the panelists, read all of those articles that were mentioned, follow their social media, all of that information is outlined on the SDC website, and that is sdc.asuw.org. And the recording of this event will also be available on that website, probably in a couple hours once it uploads and all of that. I'll make it available there. The questions that we didn't get to will be there. Yes, thank you so much. Also, once you leave this, you should have a survey open in your browser. If you have any feedback for us, if anything was inaccessible to you, please let us know. We appreciate it. Thank you so much.